Any swelling lying in the parotid region is a parotid swelling unless proven otherwise. So what is a parotid region? This is a zygomatic process. So one line goes here,
Two horizontal.
the other line goes across the angle of the mandible. And then midpoint of this line, one vertical line, and along the mastoid process, another vertical line. So we have a square. That square is called a parotid region. And the significance of parotid region is any swelling lying in the parotid region is a parotid swelling unless proven otherwise. It's clear?
Yes.
Now look at this swelling. The skin is tense, shiny,
Erythematous.
erythematous, correct. And you can even see pode around here. The same thing that you observed, huh? See? It's tender also. What is this structure? जिसके लिए मैंने बुलाया था अभी तुम दोनों को.
Sternocleidomastoid.
Trapezius, okay? It's neither of the two.
That
It
is
is just
ma-
platysma. When if you do this, this platysma becomes prominent. बचपन में खेलते हैं ना लोग.
Yes.
You become a demon, पूरा. उन्हें देखो बन के दिखाया. That is platysma. And platysma is a part of skin. Why do we call platysma a fat sandwich?
So just beneath the skin. I'm not.
Platysma is called a fat sandwich. Fat on either side. It lies very interestingly. It's a muscle of the skin only, not. It's a part of the system. What is the supply? Facial nerve.
Facial.
What's the blood supply?
Facial
artery. And it's a muscle of facial expression, right?
Yes, sir.
So this is what the swelling is. I have not palpated as yet. But if I was to palpate, it's a variegated consistency, but the patient is tender, so I would not like to bother him. Softer, harder, firmer. All three consistencies are included. That becomes variegated. Variable means more than one type, but variegated means all three types. Now some parts are evolving into cancer, some parts are
Dissolve.
dissolving into cancer, from cancer into necrosis, and some are cancer. This is why three. Classical parotid swelling would be lifting the ear lobules. Classical I'm saying, but you can see there is a gap in between. So if it goes in this fossa, retromandibular fossa, then it will lift up the
Ear lobule.
ear lobule because it will lift up the canal. So it's not lifting it here, which doesn't make it, not that it is not malignancy. Hard inconsistency fixed. If this was a malignancy, I would be expecting more things. दांत दिखाइए जोर से. There is a mild deviation, not much, and the teeth show that he has had a good time. Now, a lot of tobacco chewing. You can see that the staining, melanoplakia, erythroplakia, submucous fibrosis. They're all three in this one picture. All of them are precancers, not precancerous condition. They are precancers. They're called as oral precancers. That's the difference. But you don't see a gross facial involvement. That's a large parotid tumor which is malignant. It should have happened. This could have happened due to ramus mandibularis, which is coming from this area. Just about, it's also a branch of facial nerve. फिर से दांत दिखाइएगा. See, mild deviation. छोड़ दीजिए आराम से, ढीला छोड़ दीजिए. छोड़ दीजिए आराम से, मुंह बंद करिए. आंख जोर से बंद करिए. Good.
Forehead wrinkles normally present.
आंख खोलिए, ऊपर देखिए, नीचे देखिए. So the wrinkles are present. So only ramus mandibularis is involved, which doesn't really go with the parotid malignancy the way it should. Or maybe it's the beginning of the trouble. You don't know. And I'll also look for all head and neck swellings, always do an intraoral examination. Torch, please. मुंह खोलिएगा. So mouth opening is adequate, so no trismus. And you can see a lesion in the tonsillar fossa. Look there, where the torch is. Tonsillar. आप बोलिएगा. कैसे बोलिए? मुंह खोल दीजिए पूरा. अब आप बोलिए. That's where the growth is. This was the second primary, and we thought this is a primary and this is a node, or this is a primary and that is ulcerated inside. But the tonsil looks all right. These are the possibilities, no?
Yes, sir.
So naturally, the patient was subjected to investigations. Investigations included clinical examination has been done, imaging like ultrasound, and then biopsy from both. Core biopsy, the FNAC from the parotid shows mucoepidermoid carcinoma, and the biopsy from the mucosal lesion shows squamous cell carcinoma. So they are two different primaries. We cannot link the two because the pathology is different. This is mucoepidermoid carcinoma is a very common cancer of the parotid, but no facial involvement. So if I was to even have a doubt about the report, I'll take that as a primary rather than an extension of this, because in between I don't find any deep lobe involvement, because unless the parotid deep lobe is involved, how will it get into the oral cavity or in the region of the tonsillar fossa? So my impression is there are two primaries right now. One is to do with the parotid, the other one is to do with the inner lining of the oral cavity, oropharynx. I'll then obviously start looking for the lymph nodes. Can you hold this? And for looking for the lymph nodes, go behind the patient. Flex his neck, relax the fascia. Level 1A, 1B, 2, 3, 4, 5. Here the whole area is occupied, is covered. So it's extending quite behind, right behind the, if I turn the head this side, you'll get a better idea. That's posterior triangle. 1A, no node here, no node here. Unusual for such a large parotid not to produce any metastasis to the lymph nodes. Present with this kind of a picture, I have to look at whether it's resectable or not. Otherwise, patient goes in for some sort of a neoadjuvant. The inner lesion looks resectable to me, and there is no trismus, so I have no contiguous involvement of the pterygoids, medial and lateral pterygoids. So we can think of taking the patient upwards. You understand?
Yes.
So we have found that there are two primaries, but clinically, if you have to make an impression, you can't make a diagnosis of two, so you would have thought of one cause. If they were to look for one, then there's a primary in the oral cavity which is to produce a lymph node involvement, which is N3 disease. It's a large lymph node more than 6 centimeters. Clear?
This oral cavity lesion is located quite posteriorly. Surgically, how will we be approaching the resection in this case for the primary lesion?
The location of the lesion, if this was the primary lesion, it will be oropharynx. And the treatment for oropharynx is chemoradiation. Upfront, no surgery. Because of the behavior of the tumor. Secondly, it is, yes, you're right. With a robot, it's possible to go posteriorly, but otherwise, manually, physically, not possible to get a clear margin posteriorly. Patient doesn't go for surgery. But one option was, if I do radical parotidectomy, I take out the mucosa along with it, the massive reconstruction. Huge morbidity. The patient should actually go in for chemoradiation. It's better to put the patient chemoradiation because they do well. Mucoepidermoid carcinoma, the treatment of choice is surgery. So if on account of mucoepidermoid I go for surgery, for radical parotidectomy and mucosa should be excised along. There's no big deal about it. That Nigoda is not going to take us any effort.